name's Lover. I'm a core surgical trainee in the Northwest, and I'm also the BSMA IMG lead. Thank you guys for all coming, so we can see some new faces. I can see also people that we've done a lot of courses with, so I'm very happy that you're all here, and also the other allied healthcare professionals, so thank you very much. So what we're going to do now is we're going to present our keynote speaker. So before we present him, I just want to ask a few questions. How many of you guys have met a Somali consultant, or in any part of where you've worked? Have you met a Somali consultant? I can see a few hands, yeah. So I've worked in the NHS for 6 years, and I've never met a Somali consultant. So while I was working in neurosurgery at the Walton Centre, I was lucky enough to meet Mr. Jibril Farah, Consultant Neurosurgeon. And the interaction that we had, because I've never met someone that was a Somali consultant that could, provide support, and once you start talking to them, they can give you some background of how you can navigate the NHS. So it was really nice meeting him, and immediately, within seconds, we had a special moment. He gave me his contact details, his number, and everything. That was really lovely. So a little bit of background about Mr. Farah. Mr. Farah is a consultant neurosurgeon at the Walton Centre. He's got an extensive academic research background. He's also the clinical lead functional neurosurgery at the Walton Centre, and also a senior Royal College of Surgeons fellowship program leader. So he's probably going to talk about more about himself in terms of his accomplishments and everything. But I just wanted to also add that within the neurosurgical department, he's very well respected. I've seen his interactions with patients, and it was absolutely wonderful to see that. So I know Zakaria mentioned earlier on about Somali patients and how much they really enjoy seeing Somali doctors, Somali healthcare professionals. So for me, seeing a Somali consultant was wonderful. So if we can all give a hand of applause, for Mr. Jibril Farah.
Thank you very much for the kind introduction. I'm Jibril, and I'm one of the consultants in the Walton Centre. I'm going to talk about my career path and part of how can I possibly advise you. You look very young, and I feel very old, actually. So, as I said, I'm Jibril. This is Liverpool. It's an old picture of Liverpool before they built all the exhibition centre. So nowadays you don't see that. This is the hospital where I'm working, and this is the Walton Centre. Not many people know that the Walton Centre is a self-contained neurosurgical centre. It's the largest neurosurgical centre in the country. Queen Square is the only other self-contained neurosurgical centre currently in place. We don't have an accident emergency. We just deal with neuroscience, and therefore neurology, neurosurgery, and everything which is linked with it. And we have quite a large unit, 8 operating theatre, and intraoperative MR scan, and my department is a quite large one, 4 wards, I think something like 35 ITU beds. So I've been lucky enough to get a consultant job there and to be trained in that hospital. But where I'm coming from, so I was born here, which is Rome. And I give you a picture of the classical Rome, but there is a place that not a lot of people knows, which is the Grand Mosque of Rome, which has been built in the 80s and is the largest mosque in Europe, which was built with the money of the Saudi. And this is the inside of the mosque, and is a cultural center, not only a mosque, and is taking a quite significant area of the east part of the city. After I was born, I actually moved to Mogadishu, and I lived in Mogadishu for till I was 8 years, and then I went back to Italy, and then went back in the 80s. Possibly not many of you have been in Mogadishu. It was a beautiful city. Nowadays it's all destroyed, and what you can see is the mosque in the center of the city. This is one of the main markets, and that one was a beautiful hotel which was nearby the city. What hasn't changed is the seaside, and this was the seaside nearby Jazeera, And I used to live in the Lido, and I used to go on the coral reef and walking across the street from my house each morning. And then we went to Jazeera, which was a beautiful beach, and was like 1 hour drive from there. Country was very different from what it is now. And this is my father. My father was a pediatrician, and he was the director of Medina Hospital in the 60s. And this one is a picture of him during a vaccination campaign in the south of Somalia when the Masai were still living in that area. And this is an up-to-date picture of the Medina Hospital. And he studied in Rome, and then he went to Switzerland for specialization, and then he went back to Somalia and he took over the Medina Hospital, which at that stage was the hospital of the police. So it was linked with the chief of police of the city. And he actually grew up in what is nowadays pirate capital of Somalia, so Ale. And he grew up in that area, and he moved down to Mogadishu with all the family. So he died in 1972, and what was an infrastructure, and a hospital infrastructure, a medical infrastructure that was in Mogadishu in the south of Somalia. I'm not familiar with the other part, has been completely destroyed and is in existence on what is now. So this is me, and what has been my career path. So I didn't have much choice when I grew up. I'm the son of a doctor, and I was supposed to be a doctor, and I didn't really have any alternative. So I went to medical school when I was 17 years old. I didn't at that stage want to go to medical school particularly. But I went, and I said to my mother, I'm going to try and see if I like it and then don't like it. So I liked it, and I got my MD and PhD in 1995 in Italy. Italy is a strange place for medical school, very different from the UK. There is a lot of book studying and very much little patient experience. The UK is much more hands-on experience. And when I finished my medical study, I was lucky enough not to have to do the military service, and therefore I said, let's go and see how is the UK. And my cousin was living in London, and therefore I stayed in London. The medical system in the UK at that stage was very different from what you have in this moment in time. Used to be based on a house job out of medical school, and then there were a lot of SHO job, and there were 6 months contract, and you moved around the country. So at that stage I thought, you know what, let's stay here for 1 year and a half. And some money. It was very easy to get an SHO job. So I got an SHO job in neurosurgery in Liverpool. Then I got a rotation of 4 years of SHO job in general surgery. And I stayed without really the intention of permanently staying within the UK. I did a lot of general surgical job because I wanted to go back to Somalia. And therefore, at that stage, I thought, you know what, I'll get general surgical experience. I learned how to operate, and at that stage the SHO used to run their independent theatre list, and therefore after 4 to 5 years I was quite independent on a surgical point of view. I realized that the situation in Somalia wasn't really getting better, and therefore I thought, I better find something different, and I went into neurosurgery, and therefore I went back to what was my intention to do, neuroscience. I worked as a locum registrar in Nottingham for 6 months, and then with the Kalman system I got a registrar position and a career registrar. So between 2001 and 2007 I was a registrar in the Walton Centre, and I was generally trained in every aspect of neurosurgery, and we used to do on call wise 1 in 5, 1 in 6, And in this period of time, I lived in a hospital ground. I never had a house for all these years. So from 96 up to 2004, 2005, I lived in the hospital ground because the on-call were so many that there was no point in me. Practically, I didn't have a life, really. After I finished and I got my CCT, I went for fellowship, and I went to Germany because it was a very good epilepsy program, and I stayed in Germany for 3 months, and then I went to Canada for another 3 months for movement disorder DBS program, and I was lucky enough to be appointed immediately following that. So I was appointed at the end of 2007 as a consultant neurosurgeon, and I took the job of my predecessor. I was lucky because they actually nurtured me to take that position. So from year 3 as a registrar, I was actually trained to take that job. And I've been a consultant since 2007, which has been quite a long time. Now, what are my current position? I've got a very large practice. I specialize in functional neurosurgery, and therefore I cover movement disorder, and I cover epilepsy, neuro-oncology in eloquent area, and chronic pain, trigeminal neuralgia, and unfortunately for my sins, I still do on-call, and I've got a general practice, which I hope to get rid of. I run the National Service for Thalamotomy for Essential Tremor, which covers the north of England, and we've been lucky enough to win a bid to have one of the MR focus ultrasound machine, which is 2.5 million, and we get referral for all over the country. And I run the National Service for LIT, which is the interstitial laser therapy for epilepsy. In other words, you don't operate any longer, you don't open the head of a patient, but you just put a probe and you burn it with a laser. This is a national service that covers the north of England. The south is covered by King's College. I'm the lead for all this service, and I'm the program director of the Senior Fellowship in Functional Neurosurgery and Epilepsy. I'm a member of the CRG, which is the clinical reference group for adult neurosurgery and spine surgery, and I've got collaboration with the university, but I've never been very much into academia, and therefore I just help generally other people. So let's talk about neurosurgery. So what is neurosurgery? Neurosurgery is changing in a dramatic manner, and possibly functional neurosurgery, and what I do used to be a niche subspecialty with very small number and volume, and nowadays will cover in the vast majority of unit a significant chunk. Epilepsy has improved significantly, so we can actually cure patients, and the epilepsy program are both adult and pediatric epilepsy. Is very rewarding because the patient that you treat, if you can treat them, are very young, and they will live a productive life if you actually get the surgery and the selection process correct. The epilepsy program has been improved, and possibly in the Walton Centre we are lucky enough to have the National Service for LIT, which is the interstitial laser therapy, which is going to be a game changer in the UK, has been a game changer in the US, and will actually enable to perform surgery with a very small twist drill and insertion of a small probe, and therefore you don't need to open the head any longer, you don't have a big craniotomy. And the future will move towards this direction. This kind of technology can be utilized in neuro-oncology. I do a lot of awake craniotomy and resection in eloquent area, which are quite, I found them quite nice and challenging, and is, I would say, the nice part of neuro-oncology. Trigeminal neuralgia is another area of neurosurgery which is very much under estimated. Within the south of England, there is a service which is very much split between skull-based surgeon and pain anaesthetist. In Liverpool, we are lucky enough to concentrate everything, so we have one of the largest practice of trigeminal neuralgia. The movement disorder is another interesting part for a Western country. In other words, movement disorder are thriving in Western country because there is an old population. When you have a young population, the movement disorder are limited to dystonia in children, primary dystonia and secondary dystonia. The movement disorder here is mainly patient in their 70s or 80s, which develop essential tremor, Parkinson, and this kind of condition. Naturally, if you move in other parts of the world, just for example Dubai or the Middle East, the population is much younger, and this kind of pathology you don't have it. In Somalia it's practically inexistent. But for people who want to stay within a European country, this area is going to be a significant chunk of a neurosurgical practice in the future. In the UK they don't have children and they've got elderly people for the vast majority. Spasticity is another part of my practice and neurosurgery, and the treatment of spasticity is, I would say, rewarding because enable actually to correct certain condition, for example MS-related spasticity. Also spasticity in children is relevant in third world country. Neurological condition at birth, for example, can give spasticity, spastic diplegia, and it's much more common than you can imagine, and you can actually treat this either with a pump or with an SCDR. And then the other area of neurosurgery is cancer pain. Naturally, this is my practice, and this is what I do, and it's quite large. Neurosurgery is not only that. There is a component of vascular neurosurgery which is shifting towards the neuroradiologist. More and more people are treated with the interventional technique more than open craniotomy. And then there is pediatric neurosurgery, which is very interesting, very relevant to Somali doctor who wants to go back, because you will have a quite large cohort of patient to treat. Here in the UK, it's very, very small in comparison, and again, very rewarding to treat both tumors and benign condition. So this is more or less an overview of neurosurgery. And where neurosurgery is going in the future, and what has been my experience in all this year in the United Kingdom. I came here, and the system was slightly different from the system that you have at the moment. At the moment, the system that you have as a junior doctor is much more structured and cage-based. In other words, you do your house job and then you go into a subspecialty without having the possibility actually to try different subspecialty. That luxury was present for my generation, and I had the opportunity to actually work in general surgery, orthopedics, accident emergency before taking a final decision. But some of my colleagues, for example, worked in general medicine before going into neurosurgery. Possibly the advantage that we had was an exposure to surgical pathology and a caseload that was superior to the caseload that you have in this moment in time, and therefore the number of practical experience that you have is going to be more limited that we had. My advice for who wants to do surgery is to remember that surgery is a practical specialty, and therefore you need to operate. And that is the most important thing. If you are able to operate, and you are able to operate well, you are able to defend yourself from medical legal cases, you are able actually to avoid the situation in which you are exposed, and you will progress in your career. Yes, it's true, there will be obstacles, and I think the President mentioned those obstacles in a very polite manner. And those obstacles will be present within the UK for the year to come. They will not change, and it's very important that you support each other, but it's very important that you understand that the better you are, the more good you are as a doctor, the more you're able to defend yourself. Yes, you're correct. The General Medical Council will have a significant bias towards non-white British doctor. And I can tell you from my own personal experience that I had what is called a GMC provisional inquiry on a patient that I didn't even operate on, just because she complained about me and she said I was sexist. And that inquiry lasted 2 months to 3 months. So it's not a tribunal, it's an inquiry with medical legal opinion. And then I asked the General Medical Council why you're actually making an inquiry with no ground, and you ask for a medical legal opinion at the cost of the medical legal opinion, and naturally I didn't have any answer. Then if you look at the GMC website, you will realize that at each given time, those doctors who are suspended, they're all foreigner. Very, very few are British. The one that they are British generally is drink and driving. So they get done for drink and driving, and then they get suspended. But this is not going to be. It's not going to change in the year to come. This is the reality that you will find. But the way to avoid it is to be good what you do. And when the provisional inquiry for me was completed, the medical legal expert congratulated me for my practice and the way I ran the practice. So that one was the conclusion of it. Surgical skill, very important. For who does surgery, people are concentrating nowadays on PhD, academia, paper. Surgery is a practical specialty. You need to be able to use your hand and to operate on your patient, and that is the most important thing in my opinion. Things are different if you want to continue your career in this country, or if you want to move back. So when I when I moved here, my intention was to go back, and therefore I went into a subspecialty that was pertinent and relevant to what I seen when I was a little kid, and therefore general surgery. I remember the big general surgical hospital was the Digfair, and general surgery, thyroid, colon, hernia were all relevant. Obs and gynae is very much relevant within the current environment in Somalia. Naturally, if you are deciding to stay within the United Kingdom or Western world, or so-called developed world, the subspecialty will be different in the sense that neurosurgery, for example, in a developed country is limited to pediatric care, hydrocephalus, trauma, but what I personally do, which is a very expensive type of surgery and procedure and require millions of pounds of hardware and kit, it's not something that is really relevant for a healthcare system within Somalia. So that is an important choice that you make when you decide where to go with your career. If you decide to say, I'm going to stay in the UK, then I would personally, if I was starting again, go into interventional neuroradiology, general medicine, or neurology, or geriatrics, and you will find for sure a job. If you decide to go back, then is different. General surgery, for me, obs and gynae. Obs and gynae is very important. Delivery of babies in a country in which the average couple will have 6 to 7 children is very important. And the provision are not particularly good in this moment in time. General medicine, infection disease. Infection disease is possibly certain areas of Somalia will be a paradise for an infection disease consultant, because they will have a condition that they won't be able to see in a different area of the country. What are the current provision? And when I've been asked to give a talk here, and I made a couple of telephone calls to see what was in Somalia in this moment in time. So what you see there is the rebuilt DIGFA, which is very different from the DIGFA that I remember, and where I had my circumcision. It was a very different building, and has been opened by Erdogan, and is a general medical hospital. And I asked how is the current provision. The current provision actually is supported by the World Bank, and apparently the World Bank is supporting part of the doctor in Somalia, particularly in the south and in Puntland. I'm not sure about Somaliland. And it's a very big program, but there are all generally foreigner doctors which are employed. The facility are a bit of a question mark in the sense that I couldn't really get a feel on what the facility are. But actually, if people are looking at rebuilding a healthcare system, then you go back to drawing line, and what you need is the basic. And the basic is really obs and gynae, general GP practice, accident emergency or basic accident emergency, and then progressively you can build on that in a structured manner till you have a whole delivery of care. And actually, this will be for you as a future generation to see if you want to go back. The generation of my father went all back, and they were very happy going back. Surely it was a much more peaceful place than is in this moment in time, but it's, I would say, a beautiful country to live, and I had the privilege to live there very happy years. And that's it for me. Thank you very much.
Any questions at all for? Right?
Yeah, Jazakallah khair, it's Jibril. Jazakallah khair. I would just like to ask if somebody wants like half and half, like part-time going back home and then partly working in here, for example, or might be like training people back home as a neurosurgeon, for example, would the skills that we study in here, do you think it will be relevant if I go back? Like, I mean, like, this will be more advanced and easy. You are expecting that we won't get like fancy things, like drill, everything won't be. So it will be like, do you think a better way of training, like, if you got my question.
Yeah, I got your question. So there are, remember, you have to look at conditions, okay? So there will be condition like trauma, epidural hematoma, acute subdural hematoma, hydrocephalus in children, so a simple shunt. And it's not really the drill. Nowadays you can get that pretty cheap, but the remit of what you are treating is going to be, to a certain degree and extent, limited. So how many extradural hematoma or how many shunt in pediatric population you are going to do, limited. So if you are comparing that to what in reality is the actual medical need. So the medical need is really prevention of infection disease. The need is prevention of mortality in birth. And I was speaking with my cousin, and my aunt delivered one of my nephew in the house in Mogadishu when she was there. But that kind of skill of be able to deliver from women is lost over time. And therefore obs and gynae is very important. very, very important component. Yeah, you can do neurosurgery. I looked at it and I would have been very happy in my job plan to go back for a limited amount of time, train people. That kind of facility is difficult. And there is another truth, which is the ONG, the non-governmental organization, tend to bring white Caucasian doctor to African country. They don't tend to appoint local individual, and it's a bit of a mafia, I would say. I remember asking, I remember asking King's College. King's College has some cooperation with Somaliland and Hargeisa. I couldn't get any information out of them up to now. I remember I phoned them 3 times and I didn't. I think you need to have basic provision. Then neurosurgery, surely you can have some basic neurosurgery, but the need is different. You need to restructure a whole healthcare system. One of the important role will be for the individual actually to be able to build an healthcare system from practically nothing, because in this moment in time the provision are very limited. Yeah.
Any more questions? Time for one more.
Hi, thank you for the speech. It's really
Yeah.
good. Do patients in Somalia like to go to GPs, or do they just like to go to specialists straight away? Is there a need for primary care physicians in Somalia?
Yes, I think so. I think they. Okay, I don't think there is. There is there wasn't, but there is a difference towards a doctor in the Somali community that I found here in the UK. But there wasn't in Somalia. But then again, you're looking at different things, because the hospital when I was a kid were run by all Somali doctors. So the Dikfer was full of surgeon, anesthetist. My father's hospital was staffed completely by doctors which were trained in a foreign country, and then they came back. They were trained during the 60s, and then 70s and 80s they went back, and they were all staffed by Somali doctor, and therefore there was patient used to go quite a lot to hospitals and to the GP, and there was a trust. I don't think that you can equate what you see here in the NHS. I think here in the NHS there is a difference of Somali patient to go to an NHS trust because they don't trust them. Rightly and wrongly, and the same thing is I found in the US, but I'm pretty sure that if they had Somali doctor in Somalia, they will go there. Yeah, for sure.
Fantastic. Okay, one more.
It's not really a question, but I just wanted to say, when it comes to the doctors, I think there is a real need for specialists in Somalia, because when I was there last year, there was obviously, as you mentioned, Somalia has a lot of babies. Around 500,000 babies are born every year, and about 135,000 die from infectious diseases. A lot of babies that were born where I was working at in Galkayo, they had hydrocephalus with so many cases, and the kids would just die. They wouldn't be able to cope. A lot of families were not able to get the kids across the border to Ethiopia to get help. So there is a real need for specialists. There's a lot of obstetric doctors in Somalia, especially in the Puntland area, but there's a real deficit of orthopedic doctors, other specialist doctors. That's such a pertinent need that exists in Somalia that needs to be filled. So I just wanted to say that.
Yeah, I agree with you. Yeah, absolutely.
Fantastic. Can we give another round of applause to you?
Thank you very much.